Thanks, Mike. Morning, everyone. Hello to everyone I've met, and I look forward to meeting all the new fellows on the call. As Mike said, this is my first day back, so if there's anything I say incorrect, feel free to correct me, but I'll do the best I can here. This lecture was added to the series about 4 or 5 years ago based on feedback from the fellows, and really this will be a little bit more workflow and operational compared to maybe some of the other lectures, but the fellow group thought it was valuable to kind of review some of the UW Health processes related to oral chemotherapy or oral oncolytics for the fellows prior to starting. So that'll be the focus today. In the past, we had also covered chemotherapy council and chemotherapy council workflows. I know that Heather touched on them a little bit in the series earlier, so I won't be talking about that today. So I expect that this won't go the full hour, and we should be able to get you back some time. So with that, I will go ahead. So here's what we'll be covering today. The landscape of oral oncolytic management, and then really spend the majority of time talking about our program here at UW Health and kind of all of the workflow and operational components that go into that. And then finally at the end, I'll just briefly touch on our specialty mail service operation we have here, which is the specialty pharmacy service that actually fills our oral oncolytics. So I thought that it would be important for you to just understand kind of those operations and where our patients actually receive their medications. So I know everyone knows this, but kind of the reason for all of this in that, of course, oral chemotherapy is becoming so important for so many of our patients. When this boom initially hit, we had a lot of unique challenges, things like high costs, access, complicated dosing regimens, adverse effect management in the home setting, and really this reliance on patients rather than maybe us for the in-clinic therapies, reliance on patients to identify those side effects, report them, and manage them. So these are kind of some of the unique challenges that we try to address with these workflows. I wanted to just talk a little bit about our story here at UW Health and kind of where a lot of this has come from, but really over the last 6 or 7 years, we've fundamentally changed many of our workflows for how we manage these patients. There was a group that convened, I believe this was about 2014, when we were having a lot of kind of misadventures at the time, and some of those I've described here. But at that time in our history, we really were having a lot of noncompliance with our electronic treatment plans. We had handwritten orders at that time. We had examples of wrong doses of medications that were being prescribed to pharmacies, and just kind of a general lack of understanding at times from patients. We also at that time did an internal QA project, and we saw a high percentage of noncompliance with our policies at that time related to oral chemotherapy. So at that time, our group convened and made a series of changes, some of which I'll present here today, surrounding our oral chemotherapy workflows to try to increase the safety as well as hopefully improve outcomes of patients that are receiving these medications. A couple of other specific examples that we had at that time was we were challenged in terms of what our process was in terms of consent for oral chemotherapy, what our processes were in terms of education, who was doing it, what types of materials were we providing. Our monitoring was inconsistent at that time, and then our documentation, while it was going into the EMR, a lot of times was inconsistent across different places in the patient's chart. So really, we've really based a lot of these workflows on the work that has come from ASCO as well as ONS. So many of you are familiar that ASCO ONS puts out chemotherapy safety standards. They publish these typically every 3 to 4 years. And these give centers really a series of recommendations to, again, create the most safe and best practice standards for their primarily ambulatory settings. So really throughout our history with these workflows, we really based kind of our gap analyses off of these standards. Many of you are familiar with COPI as well, or the Quality Oncology Practice Initiative. So this is something that ASCO guides. So it's a quality program, again, designed for outpatient practices to really create, this best practice environment. So we here at UW Health do not formally possess the COPI certification, but we do use COPI as essentially a backbone to do self-examination and self-assessments to make sure that our workflows are best practice and the safest possible. So again, this is really where we look at our internal oral chemotherapy workflows to make sure we align with this effort. So we've had a series of gap analyses, again, between these recommendations and what we do here, which really have created our current policies and procedures today. So that's kind of the bulk of what I'm going to review with you. So again, these are the areas that we have existing policies or procedures, policy prescribing, dose modifications we'll talk about, prospective oral order review, education, monitoring, and then also for what we do when patients discontinue their treatment. So the first, I wanted to start with our policy. So I think this has been discussed at other talks as well, but this is an important one to be familiar with as a fellow here, and this is policy 6.1.1, which really governs all of our chemotherapy processes. So that includes informed consent, ordering, verification, administration, documentation, and then also education. So what I talked about is one of our challenges that had existed is that we really knew that we needed to define what exactly is considered chemotherapy at UW Health. So as we have these products that are continually getting FDA approved, there sometimes is a little bit of gray area in terms of what is considered chemotherapy. So I'm actually just going to pull this up briefly here. But if you would ever want to reference this policy, you could just search for 6.1.1 on UConnect, and that will take you to the policy. So what we have, the policy comes up first, but if you look in the related documents, there's a couple of other supplemental pieces to this. So the important one and related to definition of chemotherapy is Appendix A. So if you click open that document, we keep essentially a running list of all of the agents that we consider chemotherapy here at UW Health. So if you're ever in question, you could go to this list. I think really where this comes into play often is related to the informed consent process. So if an agent is listed on this list and is being used for an oncologic indication, then the answer, if the question would be, would informed consent be required at UW Health? The answer would be yes. We would need to get informed consent per policy because it is a medication we define as chemo here at UW Health for an oncologic indication. A couple just things to note on this list. So we do include some, say, hormonal types of agents. So medication like enzalutamide, for example, we do consider chemotherapy here at UW Health. So that is one that would require informed consent, and all of these processes apply to. However, some other hormonal medications, things like tamoxifen, for example, in the breast cancer space, is not included on this list. So tamoxifen would essentially, be outside all of these policy and procedure things we'll talk about today. Are there any questions about this definition or this agent list? Okay. And then the other piece to this policy that I want to just quickly review, if we go back to our related documents, is we do have an appendix that specifically is related to oral chemotherapy. So that's Appendix B to this policy. So a lot of the things that we'll talk about today in the space of ordering, order verification, education, and monitoring are actually spelled out more specifically in this appendix related to oral chemotherapy. So that was a relatively recent update that we made just to, again, provide clarity for how we're managing our oral oncolytic agents. So turning to prescribing, so we touched on informed consent already. So again, it's important to note that here at UW Health, we do require informed consent for oral oncolytics. So again, if there's a question of, what is or is not required, I'd point you to that appendix off of policy 6.1.1. But in general, we do provide informed consent for all of those agents. And then we do utilize Beacon treatment plans here via our Epic EMR platform. I'm sure many of you are familiar with. We do those Beacon plans are inclusive of our oral chemotherapy. So we do require Beacon treatment plans to be utilized for patients that are on oral oncolytics. I did want to point out that we do currently utilize what we call kind of a hybrid model for prescribing as it relates to Beacon, in that, again, we require that for patients that are starting oral chemotherapy, that a plan is initially placed. Again, the reason for that is that these plans will, similar to IV or in-clinic agents, will include required labs, treatment parameters, all the monitoring components that go into that. So those patients need to have a plan applied, but we do allow reordering outside of the treatment plan for select agents. So what that means is that within the Epic platform, if you're familiar with just the medication activity and just doing kind of a simple reorder in that fashion, we do allow that to happen for certain agents. So this example here is for imatinib. If you'd go to the Beacon plan, what you'd see in cycles 2 and beyond for imatinib is just this placeholder order. Essentially, this isn't the actual imatinib order itself. It's just a reminder that if and when you're going to do refills for your patient, you would just order them through the medication activity. We do have some agents that we always order within the treatment plan. So some examples of those are any agents with, like, say, a REMS program, so like our Celgene agents, for example, that don't allow refills. Our clinics have found in those cases it's just easier to just continue to order them and release them from the plan. So the pharmacy team in clinic is a great resource if you have questions about this kind of prescribing model, but we've kind of worked clinic by clinic to hopefully curate their plans kind of in the best possible fashion for their workflows. I touched on refills already, but refills are allowed for the majority of orders. There are some notable exceptions. So again, products that would be under a REMS program, likely you wouldn't get involved in prescribing those as a fellow, but those would be examples where refills would be disallowed. But in general, if it's a product that if it's clinically appropriate to add refills, that is something that you would be able to do, of course, at your discretion. Dose modification, I think this was touched on potentially in a previous lecture, but we require documentation for patients that have dose modifications that are made to their plan, both for IV and oral chemotherapy. So within your navigator, there's a standard note that I have a screenshot of here that we utilize to document this change. So you can see it's pretty simple. Essentially, you're just typing in the drug, what the new dose would be, or the new regimen, and then why you've made that change. The reason that we require this, particularly with oral oncolytics, is what we found was, at times you're having patients that are needing dose modifications. Maybe it would even be outside of, say, a clinic appointment with you, where you get a phone call and the patient's having some sort of toxicity, and you communicate to that patient to make some sort of change. We ask that this modification then be put in, just because this is essentially like our internal source of truth for what the current treatment plan is for that patient. Prior to this workflow, what we found was we were having essentially problems where staff was digging through progress notes and not able to quickly identify really what the current plan was. So I think the feedback has been positive across the disciplines that this, again, really allows us to have this central source of truth to really quickly see, particularly in the case of oral chemotherapy, what regimen the patient is currently taking. Prospective order reviews. So this is a service that we provide on the pharmacy side for patients. So we essentially, what this is a prospective review of all orders that are generated from Epic or a HealthLink platform. So previously, I talked about the misadventures that we had, but what we were having challenges with was we had a very robust independent double check process for our in-clinic treatments that occurs within Epic, but previous to this workflow, that was missing kind of on this outpatient side. So what was happening was we were having examples of errors in orders that were being sent to pharmacies. We had examples where orders were generated and sent to the wrong pharmacies, which was creating delays for patients ultimately receiving their medication. So this process allows us to essentially mimic what pharmacists do on the in-clinic side and provide, again, that robust double check of an order that's generated. So this is all automated. So when you are entering, when you enter a Beacon treatment plan and when that order is released, which is typically done by a nurse from the plan, that generates a notification via a pharmacist verification queue to, again, do essentially a review of that order to make sure it's appropriate clinically, as well as that we have some of the operational components in place, like prior authorization and correct destination pharmacy, for example. And that's all done via hard stop, so the order does not generate out of our EMR until that is completed. Again, we have been tracking interventions on this since we've been doing this about 5 years now, and again, have consistently found value via this workflow. What's helpful, I think, from the physician side is if you are, if you have a pharmacist in your clinic, I think what you'll find if you're working closely with them, just to, communicate to them and or the nurse that, you've signed an order and or, released an order. That's very helpful just to, again, keep everyone on the same page that this has been, released, and then we can kind of quickly see that in our verification queue and get it taken care of. And if there are any questions or things that need to be clarified, then, it's helpful to have you there and we can get that sorted out. So we do this across multiple sites within our system right now. So again, mainly for you here at our CSC and our clinics within Carbone here, but we also, just for your information, do this across our pediatric service lines, as well as our One South Park Clinic and Johnson Creek clinics as well. So we've been able to expand this just because we've really seen the value that this is providing for our patients. I'm going to shift gears a little bit now to education and some of the processes with that. So if you would reference, again, that policy 6.1.1, it does spell out what we do for education. So again, based off of COPE, it is recommending that patients have a documented education that's completed prior to cycle 1, day 1. We recognize that this can kind of be challenging for oral oncolytics, particularly given at times the actual start date of that medication is sometimes not known based off of things like, prior authorization turnaround time. Sometimes there's other things going on in the patient's case that, you're waiting on to make that determination. But I think if the take home here that really helps our overall workflow is if you have an inkling that a patient, may be starting on an oral oncolytic, particularly if you're, looking at going through your consent process. It's really helpful if you can notify one of the clinic pharmacist team who owns the outpatient education, just because that can allow us to hopefully get in, while your patient is here and do that on site to get that taken care of prior to the patient ultimately starting. What we found is, I think, given that the majority of these patients are often receiving these medications via the mail, we can do these education teaches over the phone. However, the feedback we've received, is it's most beneficial if patients are here. However, we are flexible, particularly, of course, in this time of COVID, where we've had to really move a lot of these activities to a more kind of remote setting. So just notify us if possible, and then again we can do what's most appropriate, whether that's actually meeting with the patient, or hopefully once we kind of transitioning out of some of the COVID workflows, again, having more of that face-to-face. There are some tools I wanted to just make you aware of. So we do have a portal on Uconnect, our intranet here, which I have linked here. which contains a lot of our resources related to oral chemotherapy. So we have some, these are more for nursing and pharmacy, but we do have some medication-specific sheets that kind of help guide some of what we do in terms of like our outreach calls and kind of checking in on patients. We have a link to that Appendix B, like I talked about, related to our processes. We do have a diary that we send home with patients. Again, this is provided typically by the pharmacist during the education process, but this is just a helpful tool that we have patients, use to track things that are happening and encourage them to bring them into clinic. And then finally, we do provide written education to patients. We're utilizing an external site. This is a group that is comprised of HOPA, which is the Oncology Pharmacist Group, and then ONS, which is the Oncology Nursing Group, put together a robust library of medication sheets that we essentially just remotely link out to and provide to patients that are pretty helpful material. So this link is here. If you ever wanted to provide patients with a handout, you could go to this library and just quickly link out and search by agent and just go ahead and print it out and provide it to the patient. So that link is here for your reference for any of those tools if you would find that helpful in your practice. And this is just a screenshot, again, of that diary that I highlighted. So that summarizes education. Again, I think the big take home, again, is just really helpful if you could kind of alert your nurse and pharmacist staff that's working with you, because then we can, get linked into their care and get that taken care of. Monitoring. So this screen shows the current COPE recommendations related to monitoring. So the important thing is again, this concept of adherence. So again, because patients are now really kind of in charge in the home setting of taking their medications as prescribed, we really want to be doing an assessment of what patients' adherence is, both on an initial and ongoing basis. And then additionally, we also want to of course, be assessing for toxicity as well. So that's a service that the pharmacy team does provide for patients that are taking oral oncolytics here at UW Health. So this slide really summarizes what our program is. I do have a highlight that we are kind of still recovering from some of the COVID initial changes that were in place due to some staffing challenges. But what I listed here is kind of our general process. So we do contact patients about a week after the start of a new therapy. The reason for that call is just to, again, make sure that the patient has the medication on hand, that they've started the medication, that they're taking it appropriately. Any early identification of toxicity, we found that's a really important touch point, just to avoid these cases where patients maybe didn't receive their medication or had some sort of other challenge. And then we do also contact patients every about 1 to 3 months while they're taking therapy outside of their clinic visits. This is done via a risk stratification tool that we use. So essentially, patients will receive more frequent calls if they've previously identified non-adherence or previously identified toxicity or issues with taking the medication as scheduled, just to try to use our resources as best as possible. We are able to offer these types of touch points via telephone or MyChart for patients that use MyChart and prefer an electronic type of communication. So again, we have this kind of continual monitoring outside of patients in clinic. We do document those visits, of course, as well. So all of these things like the start date, adherence concerns are documented and are sent to our ordering prescriber. So if that's you in that case, you would just receive that via in-basket, particularly if there's any concerns, that we note. So that's kind of our general, monitoring workflow. Again, note that we're still kind of recovering up to this with our COVID kind of flex down, but we do expect that we will kind of resume some of these more normal touch points, hopefully this fall. So. We use standard documentation notes, both pharmacy and nursing, so you'll see that related to oral oncolytics. So of course, we're noting access, adherence, toxicities, et cetera. And again, like I just touched on, we do send these notes to the authorizing prescriber. So, if you're leading that patient's care, we would send you that primarily via in-basket within Epic. A few other topics I wanted to just briefly touch on. So prior authorization workflows, I know Heather talked about that in her session. Again, really important, of course, for the oral oncolytic space. Just to reiterate, we do have an internal team here that works out at our Deming Way location within the pharmacy department that does all of the medication prior authorization for UW Health. That team is communicated to primarily via telephone encounters at this point. So again, nursing and pharmacy are really good resources for you. Again, if you have an inkling that you're going to think about starting an oral oncolytic, would recommend you let us know, and then we can help assist with getting that telephone encounter generated to that team. They do all of their documentation within HealthLink, so that would get return routed to you so that you're aware, if and when the prior authorization goes through. We additionally have, I think Heather touched on our medication assistance program, or our MAP program. So that's a group of technicians that essentially work with, grants or foundation assistance, or for patients that have challenges with, out-of-pocket copays. They're a great resource to link into. So that's all a piece of that workflow when you send that ultimately for prior authorization. Paper ordering for oral oncolytics, so we really avoid this if at all possible. I think what you saw is, everything that I touched on when related to our workflows rely heavily on our Epic, EMR platform. So if we're having handwritten prescriptions that are leaving the clinic, we essentially lose a lot of the ability to track that from a verification as well as monitoring perspective. So at times, especially for patients that may be filling in outside pharmacies, clinics may receive refill authorization forms via fax. I guess what we ask is, if at all possible, to generate that refill order if appropriate within HealthLink, just because, again, that goes through our verification process, and again, we can really ensure that those patients are being monitored appropriately. So just try to avoid that if at all possible. And then finally, we do have, of course, our products that do have associated REMS program. Celgene products are an example, which require additional enrollment from a provider side to prescribe. So that information would be available in the treatment plan if that were applicable to the particular agent. But the pharmacy nursing teams, help in the clinic space as well with compliance to those programs. And then finally, I did want to just talk a little bit about our PSB, or our pharmacy services building, just from a workflow perspective, so you're aware of kind of what the chain is in terms of these patients getting oral oncolytics at UW Health. So UW Health preferentially dispenses all of our specialty medications within the system, including oral chemotherapy, from our pharmacy services building, or the PSB. There's a picture there of what the building looks like, and a screenshot. So it's located out just west of the Beltline in Middleton, off of Deming Way. So it's about a 15-minute drive or so from the main hospital site here. So this center includes all of our specialty pharmacy services. So that includes our mail order operation, again, our prior authorization team. So really everything that goes into that for specialty medications. The hours of that building are kind of normal business hours, Monday through Friday, and then there is the call center hours where patients can where they can order refills are 7 to 6. So in terms of getting medication to our patients, we do prefer mail orders, and that's increasingly what our patients are preferring. So again, essentially what the workflow may look like would be, if you're starting a patient in your clinic, you may do your informed consent, link in with a pharmacist or nurse to get the education done. We send that prior authorization off, and then once that comes back, we then generate that order out to the specialty pharmacy. which then mails it out to the patient. In general, that turnaround is pretty quick from the mail side, depending on where the patient lives in the area. So can be a next day shipment as long as the patient's in the immediate area. If they're a little further out, it would be kind of that subsequent day that they would expect to receive it. And then patients can pick up directly from that location, so out on Deming Way. That's definitely a minority of patients, but some patients, just due to their situation or proximity to the building, prefer to do that. So that's something within pharmacy we'd be happy to give patients more information about if they do elect to do that. And then again, with that service, everything that I talked about with our services, like the prospective review, the outreach services, and monitoring, still are managed by our oncology team. So we work really closely with the specialty team to provide their services. So those patients are still getting all of their services provided by a pharmacist would be expert in oncology pharmacy. So just wanted to reiterate that point. So again, big takeaways with the specialty service would be they're going to be procured from that building out in Middleton off Deming Way. The majority of our patients do use the mail order service, which would then be provided once that prior authorization is resulted. So typically a next day or following day mail. Some patients do elect to pick it up out there if they'd like to. But again, all of these services still provided by our oncology team. So that's all I had in terms of slides. I thought I'd finish a little early with all the chemo council pieces. I would be happy to answer any questions, whether it's policy related, workflow related, or anything related to the operation, a specialty operation, if anyone has any.